In Northern Virginia, we have significant potential for mass casualty incidents, or MCIs. Mass casualty incidents are events involving 10 or more patients and, if not managed properly, have the potential to strain local, regional, and even state resources. In order to manage these scenarios, it's important to have a consistent process for all partners within the region. Traditionally, the EMS mass casualty response was based on the idea that patients should receive care on the scene prior to being transferred to a hospital. Initial resources were allocated to the treatment areas, and robust equipment caches were developed to allow patients to receive everything from splinting to IVs. However, this model was at odds with the perspective of trauma physicians because it actually delayed life-saving hospital-based treatment of the injured. With the introduction of Tactical Emergency Casualty Care (TECC) principles into the field of EMS, the hospitals and fire and rescue departments of Northern Virginia have now begun to bridge the treatment gap that has existed for many years. The priorities have shifted to providing on-scene treatment of only life-threatening injuries and then rapidly transporting the patients to the hospital where they can receive the surgical intervention they need. To support this approach to MCIs, 3 major areas are implemented at the scene of an event: triage, treatment, and transport. Personnel and resources are now being front-loaded into the transport area so that critical patients identified through triage can be effectively moved, tracked, and transported to an awaiting ambulance and ultimately to the designated hospital. Treatment is reserved for those limited life-saving interventions. By establishing an effective transportation group, patients can be transported to appropriate facilities quickly, which will have the greatest positive impact on their outcomes. The resources responsible for transport must focus on 3 primary elements. First, the group must coordinate the constant flow of transport units in and out of the incident with a Regional Healthcare Coordination Center. Second, transport must establish a Patient Exit Point, or PEP. The PEP is the work area where the group completes the major tasks associated with the transport of patients. Lastly, transport must maintain an accurate record and account of all patients transported. Patient tracking facilitates information handling amongst the Northern Virginia partners and also assists statewide information systems with family reunifications. In the next few minutes, we will witness how to effectively set up a transport area, coordinate resources with the RHCC, and properly track patients with the latest technology. To coordinate patient transportation at a MCI, several key positions are filled early at the scene of an incident. One of the primary positions includes the Medical Communications Coordinator, or MedCom Coordinator. The MedCom Coordinator establishes and maintains communications with RHCC, advises RHCC if additional beds or hospitals will be required, and ultimately assigns patient destination to transport units. The Transportation Group Supervisor is also a key role. The officer in charge of the first arriving transport unit initially assumes the role of Transportation Group Supervisor and works to coordinate the efforts of those working in their area. The Transportation Group Supervisor provides initial instructions on how and where to set up the transport area. The Transportation Group Supervisor makes initial contact with the RHCC and gathers a bed count of the 5 closest hospitals and 2 closest trauma centers. The Transportation Group Supervisor is assumed by the 1st EMS Supervisor, or 2nd Battalion Chief, upon arrival. Next, the transport recorder is established by the driver of the first arriving transport unit. The transport recorder ensures a disaster tag is completed and attached to each patient. Affixes the disaster tag transport record stub to the appropriate transport recorder form and enters the transport record stub information into the patient tracking system. And the last key player within the transport area is the Ambulance Coordinator. The Ambulance Coordinator manages the access, egress, positioning, and loading of transport units. The Transportation Group Supervisor, Medical Communications Coordinator, Transport Recorder, and Ambulance Coordinator must all work together to facilitate the rapid removal of patients.
Engine 210's on the scene with an overturned transit-style bus, estimating approximately 25 patients. Start me 1 MCI alarm to this location. I'll be establishing Beltway Command.
Engine 432 is on scene, taking first to assignment, starting triage.
Medic 604 is on the scene, first arriving transport unit. We will be establishing transportation group.
Since Medic 604 is the officer in charge, he will serve the role of the Transportation Group Supervisor, which includes the Medical Communications Coordinator. He designates the location of the patient exit point and then contacts the RHCC, providing an initial patient count and an incident location. The Medic 604 driver assumes the transport recorder. The transport recorder is responsible for keeping accurate accounting of all patients leaving the scene, both on paper and electronically. Once the Transportation Group Supervisor, or MedCom, and transport recorder roles are established, the crew prepares equipment for the patient exit point area. The PEP is the physical location where the patient exits the scene on their way to being loaded into the transport unit. At this point, the Transportation Group Supervisor, which is acting as the MedCom coordinator, reaches out to RHCC for hospital availability. After the second arriving suppression unit gets to the scene, the crew's job is to establish the transport corridor. They outline where units enter, stop, and load patients. Once the corridor is established, the ground ambulance coordinator informs the Transportation Group Supervisor that the area is ready for ambulances to start arriving. At this point, the EMS supervisor arrives on the scene. He assumes the role of the Transportation Group Supervisor and is given a briefing of what has taken place in the group prior to his arrival. The former Transportation Group Supervisor is now the permanent Medical Communications Coordinator. With all the key positions filled, it is now time for the patient exit point, also known as the PEP. The transport recorder uses the transport recorder form and writes down the names of the hospitals on each form. The transport recorder pulls out a set of disaster tags and sets them on the stretcher. Then the transport recorder logs into the iPad and selects the correct incident within PTS. As the transport recorder prepares for patient tracking, the MedCom coordinator connects with the RHCC to identify a list of available beds at each area facility. The MedCom coordinator tracks the information for the team on the board. Now the key areas and positions are in place for a successful patient exit. The Transportation Group Supervisor, Medical Communications Coordinator, Transport Recorder, and Ambulance Coordinator have the ability to work together and facilitate rapid removal of patients. Porters approach the PEP and connect with transporters who have a stretcher prepared. At this point, it's the Transport Recorder's job to gather the patient information from a variety of sources. The porter identifies the patient with the proper tag classification. The transport recorder grabs a disaster tag and writes the information on the transport stub. The MedCom coordinator identifies the hospital based on the categorization of the patient. The transport recorder records the hospital name on the form, and the transporter provides the unit number. After the pertinent information is gathered, the transporter peels the transport stub off and places it on the appropriate hospital form. Then hands the top part of the form to the transport unit crew. As the patient gets loaded onto the vehicle, the transport recorder puts the information into the patient tracking system. It should only take 20 to 30 seconds to process a patient through transport.
Over here, guys, for the patient exit point. What unit are you and what do you got?
414 Echo, 1 red tag male.
414 Echo, 1 red tag male. Where can I go?
Fairfax Hospital.
Okay.
Will you place this on him, please? I'm going to get a picture for identification. All right. Got a picture?
Fairfax, go. Hey guys, what's your unit? What do you have?
Medic 519, red tag female.
Medic 519, red tag female.
Take it to Fairfax Hospital.
Fairfax Hospital.
Place this on him. Get a picture.
Next patient.
As patients are being transported in the ambulance or after arriving at the hospital, it's important for the attendant in charge to populate additional information within the patient tracking system. When the scene gets busy, sometimes it can become difficult to enter data right away. But with the proper planning, you can get the information into the patient tracking system quickly. In situations where the environment is moving at a rapid pace, it's important to fill out the transport stubs every time. Then you have the ability to catch up once the action slows down. After all the patient data is entered, the Transportation Group Supervisor has the ability to view the event's comprehensive data. In the Incident Commander screen of the patient tracking system, the Transportation Group Supervisor can view the total number of patients, their tag category, and their destinations. As a result of great teamwork between the Transportation Group Supervisor, Medical Communications Coordinator, Transport Recorder, Ambulance Coordinator, and other roles, the crews in the PEP were able to quickly receive patients, assign them to appropriate medical facilities, and track their flow from the scene both on paper and electronically.